He is Dr. Franco Louie Abes. So he finished his Doctor of Medicine at the University of the Philippines, Manila, took his Master's of Science in Audiovestibular Medicine at the Ear Institute University, College of London, finished his residency training at the Department of Otorhinolaryngology at the Philippine General Hospital, Manila, an honorary research fellow at the Department of Neuro-Otology, the National Hospital of Neurology and Neurosurgery, University of London Hospitals, Queen Square, London, took his fellow and scientific research in otology, Radboud University Medical Center, Nijmegen, the Netherlands Education, and currently an active consultant at Manila Doctors Hospital and a visiting consultant at the St. Luke's Global Medical Center and Makati Medical Center. Now, to discuss the inner ear anatomy, without further ado, let me introduce our newest visiting consultant of our department, Dr. Franco Louie Abes.
Hi, good morning to everybody. Yes, so thank you. So, shall I be sharing my screen? Okay, so I'll put the share screen on and then let's see, I hope this works. Okay, so for this morning, we'll just be having a rundown because I heard that I'd only be having half an hour to discuss the inner ear, but then, as a lot of you would know, there's a lot to discuss about the inner ear. So let's just do a rundown and probably we could just ask me questions later on. I hope everybody can hear me clearly. Okay. So, a lot of you are familiar with anatomy of the inner ear, or I hope you are. So the thing is, we have a couple of things in the inner ear. So if you're familiar with your CT scans, this is the thing that you see when you cut through the cochlea on the eggshell cut. So you have here the hydrotrema, in the middle, and then the modulus, which is the medial part of your organ of Corky. So the thing is, you have a couple of compartments or a couple of scala, which are your scala media, scala vestibuli, and your scala tympani. So these are sealed spaces with tight junctions in them. The specific charges of these spaces are very important for the function of our inner ear. So you have your inner hair cells there, one row, and then you have your outer hair cells, and new ones are around 3 hair cells for every one. So that goes through around your cochlea. And then this is a clear picture, supposedly an electromicrograph of your hair cells. So both your inner and outer hair cells are all supported by other hair cells with supporting structures. And we have your tectorial membrane above there, which is essential in actually putting in the positive charges into those inner hair cells. So the thing is, sound gets transmitted to the cochlea through our oval window. Remember, your middle ear, the most important thing is your impedance matching, which means that a bigger area would be concentrated into a smaller area, which is your oval window. So all the fluids coming from the oval window would be transferred eventually to your scala tympani on the other side, and with a pressure relief port, which is the round window. So again, your scala vestibuli and scala tympani would contain perilymph, which is low in potassium, but your scala media would contain endolymph, which is rather high in potassium. So again, the oval window here, connected to your foot plate, and your round window acts as a relief port for all those fluids coming in. So the thing is, the sound gets transmitted through sound waves going into your cochlea, and this stimulates the movement of your basilar membrane. So back in 1960, if you've heard of this guy, his name is George von Békésy from Hungary. He won the Nobel Prize because of his theory with the traveling wave. So what it says is that there are vibrations in your cochlea, and the vibration of the stapes creates wave in cochlear fluids, and moving this basilar membrane up and down in a traveling wave. And in this traveling wave, there are specific places in the basilar membrane which are more sensitive to specific sound frequencies. So What determines the optimal vibration frequency at each point of your basilar membrane? So it is usually the variations in mass and stiffness from the base to the apex. So the thing is, when you uncoil the 2 3/4 turn, 2.5 turn cochlea, and then you unroll it, you will have a narrow but stiffer base, and then which is more sensitive to higher frequencies. And you will have, and as you go towards the apex, you will have a wider yet more flexible apex, which is more sensitive to low frequencies. Okay. So this is the phenomenon called tonotopicity, which says that higher frequencies are more sensitive to this narrow and thick and stiff area of your basilar membrane. But then when you go deeper into your basilar membrane, it becomes wider and thinner and more flexible, just like your speakers, right? So that's the thing. It becomes stiffer when it deals with the high frequencies, but then when you have more movement, it becomes more flexible. That's when you have a pair of two-way speakers, that you have tweeters and whoopers that move. Okay, so here is an animation of like sound going into your ear. So when you have sound going into your ear, so it comes through your external ear and goes through your external auditory canal, moves your tympanic membrane, your ossicles, and you have impedance matching. All the sound gets concentrated and transmitted to your cochlea, and when you uncoil this basilar membrane, there is tonotopicity. Remember? Towards the base, more sensitive to high frequencies. Towards the apex, it is more sensitive to lower frequencies. Just like an organ. So that is the basilar membrane tonotopicity. Okay, so this is David Kemp's drawing. These are illustrations of your inner hair cells, outer hair cells, and the relative endocochlear potential. Okay, so you have charges inside your ears, around 90 millivolts in the interstitial fluid, but then when it goes into your endolymph, it's around 80 millivolts. So you have real charges inside your ears. Reminds me of the matrix. So the thing is, when you stimulate the basilar membrane, movement in your basilar membrane goes up and down and touches, because there's no direct contact of your inner hair cells to the tectorial membrane. So the movement towards your tectorial membrane, because the thing is, towards the medial side, this basilar membrane is more adherent. So it moves like that. The lateral side moves more. So the thing is, your outer hair cells and your inner hair cells, they move towards the tectorial membrane, and then this causes the positive ions going inside your inner hair cells, which act as your transducers. So the thing is, a transducer, if you don't know what a transducer is, it's an engineering term as well. They use it. A simple transducer would be a microphone. The thing is that what a transducer does, it transforms mechanical energy into electrical signals. So an electric guitar pickup or a microphone rather would be a sound transducer. So you have many microphones inside your ear in the form of your hair cells. So the thing is, when it gets excited, it gets into a depolarized state. When it is resting, all your hair cells are in a polarized state, and if it is inhibited, it goes the other direction. So when it gets excited, the stereocilia, your hair cells, goes towards the tallest one, in that excitation direction. If it's inhibited, it goes to the opposite side. So the thing is, when you have hearing, remember I mentioned earlier von Becke's traveling wave, where there is tonotopicity, there is specific frequencies that are more sensitive to others and not. The thing is, when there is also what we call cochlear amplification. So the thing is, a lot of people we think that the outer hair cells really contribute to the more sensitive and more selective frequencies that we have, that we can detect in on our ears. So the active processes, this active amplification caused by the hair cells, are evident in what we call acoustic emissions. This, So the thing is, you have your inner hair cells, which are your primary transducers in your ears, that's why they have exclusive afferent innervations that go directly into your brain. On the other hand, you have outer hair cells, wherein most of the innervations efferent coming from your brain going onto your outer hair cells. Somehow we think that this becomes a control of that cochlear amplifier mechanism. So when it gets too loud, your brain controls your outer hair cells and tells your outer hair cells to stop the amplification. Okay? So in your outer hair cells, there is some unique motor protein called prestin, which we think contributes a lot to the activity of the amplifier mechanism of the outer hair cells. So the thing is, when you don't have your outer hair cells, it becomes less selective and less sensitive to the frequencies. Such as, for example, when you have aminoglycoside toxicity, it might cause damage to your outer hair cells. Thus, when you have aminoglycoside toxicity, patients would experience less sensitive and less selective hearing. Okay? So, when you have a passive cochlea, meaning someone dead, and then you measure the movements and frequencies and power inside the cochlea brought about by the sound wave, it becomes a more broader wave, okay, rather than the more sensitive and selective wave towards specific frequencies. When you have a live patient or a live organism, because it has the cochlear amplifier mechanism inside your inner ear. But then again, it's not solely due to just the outer hair cells. A lot of it is due to the endocochlear potential that we call. That is the positive charges inside your inner ear, your endolimb, namely. So again, 95% of all afferent innervation goes into the inner hair cells. 5% only to your outer hair cells. Okay, again, primary transducers want to go straight to your brain so that your brain hears whatever you're hearing. So that's the thing. Your brain wants to control the level of hearing, supposedly a little bit, if it goes too much, by your outer hair cells. Okay. So, in relation to everything, this is a temporal bone from our friends from Kyoto. I got it from your temporal bone. When you do a cochlear implant, this is what you do. You put a cochleostomy in, put a hole into the cochlea, put it inside your scaliotympany, and also you insert an electrode going there. So relative to that, you have your vestibular organs as well. You will see your utricular macula and sacula nearby. So the thing is, you have tight junctions also inside your inner ear. This is what I was mentioning earlier. You have endocochlear potentials inside your scala media, but then your petrolymph is the opposite way. No? So it's not really that charged that much. And then your scala media contains a lot of potassium, which also contributes to the positive ions. But then between all these scala are tight junctions or barriers because they need to keep those charges intact. If not, then, it's not efficient. So there is loss of function of your inner ear when that happens. Okay? So again, your perilymph acts in a couple of ways. So it conveys fluid displacement resulting from the stapes vibrations in response to sound, and then provides the ionic environment necessary for transduction of hair cells, and then provides a medium for exchange of nutrients and waste products between your sensory epithelia and your blood supply. So that was the cochlea, your inner ear in a nutshell. And we will discuss a little about your vestibular system. So your vestibular system's main function is to detect the head movements, really, encounter them with reflex eye movements and postural adjustments to maintain a stable vision. So it senses balance. It is critical for reflexes for posture and eye movements, and also for the five sensory end organs. And your hair cells are the sensory receptors when it comes to this, just like in your cochlea. So these are, again, spaces inside. So inside your vestibular organ, you have your endolymph, which is also high in potassium. Same goes with your saccule. But when it comes to the vestibule, scala vestibuli, it is, again, contained with perilymph. Again, on the other hand, cochlea contains endolymph once again. Okay, again, relationships. And then you have your vestibular system, which consists of a couple of things. So you have your cupula over your hair bundles. When you look at the crista, amulous ampulated ends, and we look at the hair cells, namely, when you enlarge a macula, you will see both type 1 and type 2 hair cells, which have kinocilium. So that's the difference between the inner ear and the vestibular system. So rather the cochlea and your vestibular system, or the hair cells that are embedded in your that are embedded in your on your otolithic membrane, which contain otoconia on top. So these otoconia are responsible for so the hair cells are the ones that detect, but then they detect the movement of your otoconia about these otolithic membranes. Okay, 10 more minutes. So again, depolarization. When you say there is depolarization, there is again movement towards a taller kinocilium. There is increased firing, meaning there is more electrical signals going into your nerve and going into your brain. So it tells your brain, hey, that we are moving towards this direction. Okay? But then where there is hyperpolarization, there's decreased firing when it goes to the other side. It is telling your brain we are moving in the opposite direction rather. Okay? So when you have for example, you have your lateral semicircular canals, so they are counter to each other. So when there's hyperpolarization on one side, there's depolarization on the other side. That's why when you lose function on one side, the hyperpolarization or the opposite effect will tell your brain that you are still moving on that same direction, even though you don't have the other pair anymore. So, sorry, I'm just moving all the screens. So, you have your otolithic organs, or your macula, which detect linear acceleration in gravity and changes made in the head angle. So namely, you have two organs, your utriculus and your sacculus. The otolithic membrane covers the hair cell surfaces, and you have otoconia on top. Again, the calcium carbonate crystals, or calcium phosphate sometimes. That's what they tell them. Depends on what book you read. So again, movement, and then your hair cells detect them. And then these are your otoliths. So whenever you are in linear movement, you look straight ahead, and then you look straight ahead like that, and then you tilt. So the otoliths go back. That's why the hair cells get to detect them. So again, it's almost the same when you undergo linear acceleration through. So it's just like you're tilting your head backward when you accelerate forward. So the opposite goes when you go backward. It's just almost the same when you move in a linear fashion, or when you tilt your head back, when you tilt your head forward. Okay? As shown in these pictures. So the macula is an excitation pattern due to the head tilt. So within each organ, the stereocilia of hair cells are polarized and spatially arranged such that all possible directions of linear acceleration and head tilt are presented between the utricular and the saccular otolith organ. So it's all interrelated. So going further, going to your more familiar semicircular canals to detect angular acceleration, so meaning in the spinning movement. Huh? So these are three saddle-shaped crista that you see containing hair cells and those ambulated ends usually. Then a gelatinous mass cupula at the surface with stereocilia which project into. And then you have canals and organs which are perpendicular. So you have your horizontal canals, or your lateral semicircular canal, your posterior vertical canals, your anterior vertical canals. So pairs, lateral, anterior posterior again. Okay? So you have your hair bundles with a cupula over, and these again detect movement. And when you have angular acceleration. So when you have angular acceleration, so meaning when you turn your head, or when you spin around, so it's actually the fluid, the inertia of the fluid inside, which lags the canal. So that's the thing. Because of the movement, there's movement of your cupula, which are then detected by your hair cells. Okay? So for example, when you move towards an ipsilateral direction, that's when you have those kinds of movements. So again, this is what I was telling you about earlier, depolarization, hyperpolarization in your semicircular canals. You have the push-pull activation of your semicircular canals, meaning they are paired. Okay? So you have three semicircular canals on one side. It helps sense all possible head rotation angles, and each paired with another on the opposite side of the head. So your lateral canal paired with each other, anterior right is paired with the posterior left. Your left anterior is paired with your right posterior. So this is responsible for the push-pull arrangement of the vestibular axons as well. So, it's all interconnected. So again, functional pairs, horizontal canals, posterior canals. So again, this allows the redundant reception of movement and explains compensation after unilateral vestibular loss, such as when you have vestibular neuritis or labyrinthitis, you have a stroke sometimes, or inadvertent surgery that might have damaged your lateral semicircular canals. You're more reliant on your other pair. So when it is connected to your eye movement, so when you have excitation of any of these canals, then there are corresponding movements on your eyes as well. So this is responsible for the VOR, for your vestibulo-ocular reflex. So when you have head rotation, your semicircular canals detect head rotation, goes to your vestibular nucleus and signals the oculomotor system to excite the extraocular muscles. That's why you have your corresponding eye movements. So when it comes to your semicircular canals, there are a couple of laws that were made by Ewald. He said that head and eye movements always take place in the plane of the canal. It is stimulated and in the direction of endolymph flow. Second law, in the semicircular canal, in the horizontal canal, endolymph flow towards the ampulla or the ampulopetal flow causes a greater response than endolymph flow away from the ampulla or the ampulofugal flow. In the vertical canals, the endolymph flow away from the ampulla or ampulofugal causes a greater response than your endolymph flow towards the ampulla. So all of these go into your vestibular nerves. So your utricular nerve innervates your utricle, and then your superior semicircular canal and your lateral semicircular canal. Your saccular nerve or your inferior vestibular nerve innervates your saccule and your posterior semicircular canal. Okay, this is the importance of BEMPs. If you've heard them, it distinguishes which is affected. Is it the superior vestibular canal or your inferior vestibular canal? Mostly when you have patients with vestibular neuritis that undergo BEMPs, that's when you know. Okay? So this is the physiologic pathway of the vestibular system for a review. So you have your inputs caused by head motion, from angular acceleration, linear acceleration, for your head position, And you have your peripheral system. You have your semicircular canals in your ear, your saccule, and your utricle, in which you have contributory pathways from your visual, proprioceptive, and tactile inputs as well. These are all integrated into your central nervous system. And then you have outputs. You have efferents from your forebrain, from your spinal cord, from cerebellum, and from your oculomotor system. That's why you have balance. So the key message here is that semicircular canal sends angular acceleration. Your otolithic organs sends linear acceleration. Right? Linear acceleration, angular acceleration. Okay? And then, remember, the balance system is not just in your ears. So your eyes are all involved, sensing your environment in space, from your ears as well, from your periphery. They all get integrated into your brain and then are compared to a template that should match to each other so that you have a sense of balance. But if not, then that's when you have dizziness. So with that, thank you very much for your time. Thank you for attending my lecture. That's it.
Thank you very much, Dr. Abes,
Mm-hmm.
for that very comprehensive lecture of yours. We all know that the inner ear really cannot be taught in a 30-minute time.
Yes, exactly. Sorry.
It's okay, Doctor. Doctor, we have one question here
Sure.
regarding tonotopicity. We have tonotopicity. Is high
Yes.
frequency loss, especially
Yes.
age-related hearing loss or
Mhm.
presbycusis, related to the tonotropic arrangement of the cochlea?
Yeah. Yes. So is the question, is it related to the tonotopicity? Tama ba?
Yes, sir. Yes,
Yeah.
sir.
Because yes, I think it is. Because a couple of years back in the same course, somebody asked me, I don't remember exactly who, how do you have presbycusis? My answer to this is probably wear and tear. No, it's the same. When you have high frequency loss, because remember, when you have your uncoiled basilar membrane, yung cochlea mo, di ba, when you uncoil it like that, the most proximal part, kasi, is the one that is nearest. Siya yung pinaka nababibrate most of the time. That's why you have high frequency loss. When it is age related, kapag yun kasi yung the thing is it's more proximal, no, to the external environment because it belongs into that base. So that's the thing. Yun yung una na stimulate, and there's more stimulation into the area, no. That's why, because the nature of sound is because when you have high frequencies, they are the ones that are more stimulated more. So it's because of too much vibration, too much movement. And then because of the tonotopicity, you have high frequency loss. The reason why is because they move a lot. You get worn down. That's the reason why. Because the thing is, the tonotopicity in your basilar membrane, it's not only in the basilar membrane, the basilar membrane itself, yung movement ng membrane mismo, and then your inner hair cells also have tonotopicity. Your outer hair cells also have tonotopicity. Same goes with the nerves. Lahat sila. It's very specific for frequencies. So the thing is, when you damage any of those components that lead to the very good hearing that we have, then there is loss of a sense of speech. No? So the thing is, when you have loss on specific areas on your sound, in your audiogram, sasabihin mo, yes, nakakarinig pa naman yan. There is a sense of speech. But then there are a couple of words that your patient might not hear. No? Because consonants and vowels lead to formation of words. No? So the thing is, you might not hear them adequately, especially in a language when there is a lot of high pitch, a lot of consonants, when there is affectation of the high frequencies, especially in presbyacusis. Same goes with the thing is, it's a little bit different when you have unilateral hearing loss. No? When you have unilateral hearing loss, sometimes you might see an audiogram wait, they should hear perfectly, but then there's just loss on this other ear. The problem is when you have unilateral hearing loss, there are a couple of problems, namely two, no, speech in noise and sound localization. So the thing is, you will note patients who have a difficult time conversing in groups, especially the elderly, if they have unilateral hearing loss, especially if it's confounded pa when you have hearing loss in the higher frequencies. No? So these are the things that you have to ponder on as well.
Okay, thank you, doctor.
Yes.
Now, another question, doctor. What is the most accepted currently hypothesis or reason for tinnitus, doctor?
Okay. There's a lot of things no, that cause tinnitus, but my own personal take on tinnitus, no, it's because remember that diagram that I had with the balance system. It's similar to what you have in your brain. No, your brain has central stores as well, wherein you compare them with templates. So same goes with sounds. And when you've been hearing normally, no, then your brain is expecting sounds when there are events, no, especially when you get to compare the left and the right. No, so the thing is, if you do an experiment with tinnitus, if you occlude your ear, one ear or both ears for an extended period of time, you'll actually experience tinnitus. Why? Because your brain is looking for sound. No, because it is telling you, hey, there should be hearing here. No, so that's the thing when you have tinnitus. That's why tinnitus is mostly I haven't really seen anybody who has tinnitus who has perfect hearing. No? So that's the thing, no? So get it? So if you have some form of hearing loss, the tinnitus is brought about by a brain reaction that is telling you that hey, there might be something wrong with your hearing. No? So that's why when you correct the hearing loss in patients with tinnitus, a lot of them would experience loss of tinnitus. The tinnitus would be relieved as well. No? So the thing is, it's a there are a lot of theories when it comes to tinnitus. No? One, it's physiologic, no? Meaning it's pathologic rather. When you have some form of hearing loss that is sensory neural, be it sensory neural conductive, this leads to tinnitus. When you have a blood vessel that is dehiscent, maybe your carotid or your jugular, that is causing some sound, a pulsatile sound, that's why you want to inquire about pulsatile tinnitus, no? Which is not really a phantom sound because there's really something going on. And then, when or psychological, when there's a lot of anxiety as well. You cannot disregard the psychological effect, no, that you have on hearing and dizziness because it's near the limbic system, no. So when you have very emotional and very anxious people, when they are very dizzy and they have tinnitus, the episodes become worse, no, especially when they keep on thinking about their disease, no. That's why a big strategy towards the treatment of tinnitus and dizziness is also what we call, aside from medications, rehabilitation, it is also what we call cognitive behavioral therapy, no, or psychological support. So what it essentially does is that it tells your patient that you will probably not die of your disease, no. You should, or ways that you have to cope with your disease. Huh? Because a lot of it we can recognize the fact because it's very near to the limbic system as well, so there can really be a psychological component to all of this. Okay, so did I answer that question? Yes. So
Yes, doctor. So
yes.
sa presbycusis daw po, hindi po ba siya related din siya sa blood supply ng cochlea, doctor? Another question with regard
Okay.
to presbycusis.
Sige. Okay. The thing is kasi, your blood supply of your cochlea is very small, no? It's from your cochlear artery. I didn't include it in my lecture anymore. So not really, not that much, no? It's mainly because in your inner ear, there's not a lot of blood supply by itself. So yes, the thing is, does presbyacusis cause, because there are no, I'm not so sure if it does. There are blood vessels inside your inner ear, but I do not know. Does it cause like a stroke-like lesion that can cause presbyacusis? I haven't read of anything like that. But there can be strokes that can cause hearing loss. No? Oo. Like ICA infarcts. No? Anterior inferior cerebellar artery infarcts can cause hearing loss as well. Biglang mabibingi yung patient mo. But then specifically, because when you say there's presbyacusis, there is high frequency hearing loss. Di ba? Bakit nauuna yung high frequency? Is it because of blood occlusion? Maybe not. No? Oh, I don't think so. Bakit nauna yung high frequencies? So that, no?
Okay, Doc. Thank you.
Yes.
Then last, probably, Doctor,
Yes,
any
sure.
tips to our board takers, Doctor, to remember with regards
Mag-aaral kayo. Yun lang. And ito lang, tips. Okay, so a lot of the attendees kasi are board takers, di ba? Sa atin.
Yes, Doc.
Okay, malapit na exam next week na ba? Is it next week already? Or in a couple of days? Malapit na.
Doctor. Yes, Doc.
Oh, so the thing is, okay lang yan. I passed my exam. Pampag-good moral na lang sa lahat. Okay? I passed my exam, but I missed one exam. Yun. I missed the pathology part of my exam. Because during the first day of the exam, they were announcing, syempre I was so tense. No? I think there were 6 exams during the first day. No? And then they're announcing, oh, you have till 11 o'clock to finish your exams. Okay? Your 5 exams. Your 5 exams. Siyempre, I was writing down, just writing my exams already. Yun pala, when they announced subsequently, you had till 11 o'clock to finish your 6 exams. I thought, because we had pathology that day, I thought at 11 o'clock, we'd have a slide viewing or some sort. So, pagdating ng mga 10 o'clock, sabi ko, 5th exam, hindi pa sila nagpa-pass. So, hintay ako. And all, hanggang mga 10:45, sige, bigay ko na. Because the thing is, the exam goes, you take one exam at a time. So, you take your exam. And then after that, you hand it over. They'll give you the next exam. What happened was, I gave my 5th exam 15 minutes before 11 o'clock. So, I missed the entire pathology part. Kaya okay lang yan. Mag-aral kayo na mabuti para mabawi niyo sa iba. Okay, so tips. Learn the ear because that will comprise around 1/3 of your exam. No, that's the thing. Okay, because you have the audiology part, you have your otology part, and also your anatomy part. Kahit saan niya mapupunta. No? Mix and match yan eh. Oh, so that's the thing. Learn about the ear a lot, and then siguro 1/3 of the exam you will know already. Oh. And a lot of the things from the exam, although you prescribe Cummings pa rin ba? Tama? Cummings.
Yes.
Oh, yes, Cummings. So you read Cummings and all. But I read 3 books. Oh, when it comes to that. I read Probst, I read KJ Lee, I read Cummings, I read also 2 other books. One more, yung makapal rin. And also, and then I was in between kasi it got boring. So you read journals in between articles when it comes to that. So the thing is, retention yan eh. So you also make notes, and then after, if you have notes, that's what you go back to. Oh, mas madali yun eh. Oh. So, studying tips. Okay? So, paano bang exam? Is it online?
I think, yes, Doc. I think it's
okay.
online.
Any other questions? Meron pa ba? Wala na.
I think that's all, Doctor.
Okay.
Thank you very much, Dr. Abes, for your time and for your great lecture for this morning.
Okay. Sige. Okay. See you. Good luck to all the examinees.